drink about Good evening and namaste everyone. On behalf of Intas Pharmaceutical Limited, I, Dr. Mithilesh Nayak, welcome you all to this 5th edition of Practice Pulse in Endocrinology. And today we are having an interesting debate on topic that age-related morbidity can be mitigated by hormones. And to guide us, we are having with us Dr. Subhankar Chowdhury sir. He is a professor and head department of endocrinology, SSKM Hospital, Kolkata, and he is also editor-in-chief, Indian Journal of Endocrinology and Metabolism. And to take us the debate topic, we are having Dr. Chitra ma'am as well as the Dr. Jubbin Jacob sir. So now I request Dr. Subhankar Chowdhury sir to take us further. Over to you, sir.
Hi, very good evening and a warm welcome to the current edition of Practice Pulse in Endocrinology. I hope we could convey some useful, practically useful information in the previous editions where we have discussed first about osteoporosis, then about thyroid function tests, then about hormones and hypertension. Then we had a session on SGLT2 inhibitors. And now the fifth edition is sort of on hormones as elixir of youth, if we may put it that way. If we go, we do understand the aging process involves a whole lot of things. And some of the changes that happen are indeed engineered by changes in hormone levels. We can't, as endocrinologists, as much as we would love to, we cannot claim that that's the only thing that's happening in the body that's determining the changes of aging. But there is a significant amount of hormonal changes, and it's been a topic of discussion and debate for a fair amount of time as to whether we could reverse, to a certain extent, the process of aging by intelligent application of administration of hormones. And interestingly, just before this session, I went to a site to look at, it's called Epo Medicine. I don't know whether you've all seen, looks all very nice, and it says it is an amalgamation of medical journals and medical blogs, and it's supposed to provide you concise, reliable, and what did they say, sort of information that can be checked as well. And it says about growth hormone, it says what it can do. It says it can eliminate premature aging symptoms. It can reverse biological effects of aging. So that's two points there for aging. Growth hormone can do. Reduces body fat, increases lean muscle mass, strengthens the immune system, improves sexual performance and libido, lowers blood pressure, lowers cholesterol, restores hair color, and then I got more interested, restores hair growth, so I could possibly use it. And then increases bone mass density, it says, by about 2% per year, strengthens the heart, regenerates organs, and increases energy. What else do you need? So I'm sure we'll have an excellent session. We have excellent speakers this evening. And we, of course, these may or may not be what the speakers believe what they will speak on today. This is what they have been assigned, but I'm sure they will fight their point out to the best of their abilities, and best of luck to both. We, of course, will go by the usual rule that the proponent speaks first, and then it's about 20 minutes, and then it's the opponent. And the proponent gets another shot, maybe a couple of minutes, to rebut any of the points, unfair points taken up by the opponent. So first, we have Dr. Chitra Selvan, who is Associate Professor of Endocrinology at the Ramaya Medical College at Bengaluru. She has a lot of laurels to her credit, and she has got several publications as well. And overall, what I can very sort of confidently tell about her is that she's an excellent speaker and she's an excellent person. So Jubbin, whatever she may say, it's nothing personal against you. So over to you, Chitra.
Thank you, Professor Chowdhury, for that kind.
Chitra, really you've muted yourself.
Yes, yeah. Thank you, Professor Chowdhury, for that kind introduction. And another laurel in my cap is the fact that I'm Professor Chowdhury's student, and no time like October to miss Kolkata. So I'm hoping that all of y'all are safe during COVID times, and what better way to distract ourselves from the chaos that's happening outside, but to debate about age-related morbidity and whether it can be mitigated by hormones itself. Professor Jubbin Jacob is on Twitter with me, and he tweeted out about this debate, and now my husband and my daughter are outside the door chanting, "Beat Professor Jubbin Jacob, beat Professor Jubbin Jacob." So I had to quiet them down. So I'm going to try my best. So should we be giving hormones to mitigate some of the age-related morbidity at all? And is there evidence at all? And why should we pause to talk about this? This is a slide from World Population Aging 2019 from the UN website, showing you the percentage of individuals who are aged 65 years or more. And if you see, of course, you will find a greater percentage of elderly in the developed countries, but the light blue represents our world, Eastern and Southeastern Asia. You see that we are the third in today's world, and it's projected that the number of elderly that we will be housing is likely to increase and probably move up to the second place by 2050. So this is not just an issue which is to be dealt by the developed countries. It's also very soon going to become our reality as well. And also, this is a slide which is looking at life expectancy at birth amongst the various world groups. And you see that the light blue line is slowly moving up and is projected to move up as well. So by 2050, up to 1 in 5 person is likely to be greater than 60 years or more, and up to 80% of older individuals will be living in low and middle income countries. So how are we going to optimize health for them in our context is probably going to be a conversation that we should all be interested in. And also, I discovered that this decade is the decade of healthy aging as declared by the World Health Organization, with a host of programs to increase knowledge base and also percolate resources to encourage research in this area. So quickly to pause and reflect about what aging is, Professor Chowdhury did tell us that probably hormones play a crucial role in the process of aging. The definition would be the gradual, time-dependent, heterogeneous decline of physiological functions with time. So time-dependent is important. That it is heterogeneous is also important. We are all not the same. Some of us are likely to age a little faster than the others, and some of us are not likely to show the effects of time as quickly. And all of this is probably orchestrated by numerous molecular mechanisms, yes, mediated probably through hormones, also mediated probably through food intake, the amount of insults that we experience in terms of illness, malnutrition, and all of that put together. This is a pictorial representation to suggest that frailty is not just physical frailty. There's also psychological frailty and social frailty. And the process of healthy aging can be interrupted by, let us say, periods of vulnerability, which could be in the form of an illness or a surgery or a fracture, or maybe even just a period of extraordinary emotional stress. So those are probably the windows that we must try and target, identify, and probably reduce to maybe bring that curve of our aging closer to what is represented as healthy aging. And of course, there are numerous metabolic parameters, genetic parameters, social and cultural parameters. For example, I'm sure there is a gender difference for obvious reasons, but there are also repercussions related to the socio-cultural and economic status as well. And if you can break down the composite of aging into identifiable factors which we can review individually, and maybe talk about how hormones could potentially play a role in coming together as a cumulative to mitigate morbidity related to aging. It can be broadly broken down into factors related to frailty, osteoporosis, falls maybe, and metabolic parameters related to diabetes, hypertension, which could in turn funnel into vascular disease, stroke, maybe even vascular dementia. Of course, then you have neuromuscular factors like sarcopenia, the amount of physical strength, and of course, presence of other inflammatory conditions like arthritis, and of course, there is cancer. So I'm going to maybe break into factors which are probably relevant to endocrinology and attack it head on. I'm going to start with an extremely low-hanging fruit, but it is yet something that we are all ignoring and not paying enough attention to, even as endocrinologists, is what I think. So a few weeks ago, we had a round of chat and discussion where we discovered that even as endocrinologists, we are not targeting this particular factor, and that is osteoporosis. It is without doubt that the prevalence of osteoporosis increases with age, and it's an independent risk factor. Up to 1/4 or 25% of women aged more than 65 years have osteoporosis, and up to 1/3 of women greater than 80 years have osteoporosis. And up to half of women greater than 65 have either osteopenia or osteoporosis. And it's important to understand that your BMD might not be in the osteoporotic range. And more than half the fractures happen in women whose BMD is in the osteopenic range. So we very clearly know that osteoporosis is a very, very important risk factor. And we do in and out meet individuals who are in this age bracket. And yet, if you are doing a clinical audit of our own patients, we are screening very less, we are targeting very less, treating very, very less, right? And so this is a graph which is showing you the mortality rates after an intertrochanteric fracture broken down into two eras, before 2000 and after 2000. And you see that the mortality rates are very high, even as late as 1 to 2 years after intertrochanteric fracture, which means that if an individual has an intertrochanteric fracture, the probability that we're going to lose them or they may not live up to see their next birthday is as high as 50%. And that doesn't seem to have changed majorly, although there seems to be a slight trend towards improvement in the last few years. And this is probably one space where men are also fighting for their spot under the sun. It's traditionally or maybe believed that osteoporosis is a disease which affects women. Yes, it probably does affect women much more, but men are not exempt completely. Up to 30 to 40% of all fractures which happen are in men. And men with hip fractures have greater mortality than women with hip fractures. So this is not just a disorder which is pertaining to women per se. Yet, when we talk about osteoporosis, even after they've suffered a fracture, very, very few people receive treatment. Only about 25% of women receive treatment after a fracture. About 5% of men receive treatment after being admitted for a hip fracture. So there is a lot of scope here to improve morbidity and quality of life, very, very within our own realm, what we can do in our clinic with not too much of exertion, but we don't seem to be doing that. So recently, there has been quite a few change in the recommendations by ACE, which came out in 2020, where they have clearly broken down individuals into two groups, very high risk factor and high risk factor. And in individuals who've had a prior fracture with very high risk, it is recommended that we use hormones, teriparatide and abaloparatide, and teriparatide is very freely available in our country. to bring down the risk of fractures. So it is an anabolic hormone which is available, which when given as a daily injection for a window of 18 to 24 months does increase bone quality, and I'll show you how. And this is a QCT of bone in an individual who received teriparatide for about 21 months. And you can see there that the density of the bone increases. Not just that, the architecture of the bone between the two cortex also improves. So there you have an improvement in bone quality and solid evidence to suggest that it brings down the risk of fragility fractures. So something that all endocrinologists should do, and all, let's say, orthopedicians and primary care physicians could be able to do with a little bit of hand-holding, is a hormone which is very much in our midst. And talking about fractures, let's also pause to talk about falls. We know that vitamin D deficiency is mostly asymptomatic, but it is known to contribute to increased frequency of falls. And we also have evidence to suggest that replenishing vitamin D is a very easy way of bringing down falls. Probably this is something which is something that we are waking up to, and age more than 65 years is a clear-cut indication to be screening individuals for 25-hydroxy vitamin D deficiency. If not screening, because screening is expensive, at least replacing vitamin D. So that's a hormone, and that is something that we can make sure we are covering 100% in our clinic. Moving on to a slightly different context about sarcopenia and its relevance in the contribution to aging. Sarcopenia is decreased muscle mass. Of course, we don't need to always measure muscle mass. We could probably just look at muscle strength or muscle function. Has numerous factors contributing to it. Yes, the window that we are interested in is the endocrine factor, which could be in the form of decreased growth hormone, as was highlighted, or decreased gonadal steroids, be it testosterone or estrogen. But is there something else which is very common in our world, which we are probably not paying very much attention to? And this is a slide to show you that the presence of diabetes in the context of aging is very likely to exacerbate loss of muscle or sarcopenia, which at the end of the day can lead to frailty. And if you think I'm diluting the conversation by talking about diabetes, when we're talking about aging, this is a slide from the IDF Atlas published recently, showing you the prevalence of diabetes across the age groups. If move your eyes towards the last 4 columns, and you will see that in individuals who are greater than 60 years of age, the prevalence of diabetes touches 20%. If you take the prevalence of diabetes globally across the age groups, it's roughly 9.3 to 9.6, 9.3 in women, 9.6 in men. But when you're looking at the group that we are talking about, the prevalence is much higher. That's 1 in every 5 individual who walks into your clinic over the age of 60 years has diabetes, and up to 50% of that is undiagnosed. So how strictly are we screening for diabetes in our individual? Do you at some corner of your mind think that maybe once you've crossed that window, you're less likely to have diabetes? That's something to think about, and that's an easy way to address overall well-being and muscle strength and prevent frailty and sarcopenia. Now, moving on to the actual hormones, and which could contribute specifically with sarcopenia. And I will start with the gonadal steroids of estrogen. It's all in red because everybody's scared and worried about menopause, hot flashes, and irregular periods. 1, because it's uncomfortable to talk about it. 2nd, there has been a lot of confusion in the last 2 decades. But much of that confusion came from data from the Women's Health Initiative trial, which was a large trial, which looked at 27,000 odd women aged between 50 to 79 years, which studied the effect of estrogen with medroxyprogesterone or just estrogen, and followed up for coronary heart disease, an invasive breast, and another composite index, which looked at embolism, stroke, hip fracture, and death. And what they found was, yes, although that there was benefit in terms of reduction in hip fracture, reduction in vasomotor symptoms, and diabetes, there were red flags raised by this trial in terms of increased risk of stroke, pulmonary embolism, invasive breast cancer, and coronary heart disease. If I'm going to break this down and see which arm had greater prevalence, you will see that in the arm which received MPA, which is medroxyprogesterone, they noticed an increased risk of both the heart events and the invasive breast cancer, whereas the group that received just estrogen seemed to do quite well. But another thing which was raised by the study was the fact that the women who were included in the study had a mean age of around 63 years, and they'd had menopause for about 10 years. So that was again something which could have offset many of the findings in this study, as could have been the fact that the progesterone that they chose, medroxyprogesterone acetate, is very likely to have greater adverse effects on blood pressure, carbohydrate, and lipid metabolism. And if you're talking about the absolute numbers, the differences between two groups, they are in double digits actually. So let's now look at, so it was good that this WHI confusion occurred very early. So now we have enough time to design proper trials to specifically study it instead of just prescribing hormones to women without knowing all the details about it. So this is data from the KEEPS trial, which changed the progesterone. They changed the progesterone and kept it as micronized progesterone and gave either oral estrogen or transdermal estrogen, and they followed them up for a window. And here they chose women who were just immediately postmenopause. So they had to be less than 36 months postmenopause, and they looked for increase in coronary artery calcium levels and carotid intermediate thickness, and they found no increase between the three groups. So it could be that earlier the window, no increased adverse outcomes in terms of cardiac, or it could be that the progesterone is the one which made the difference. So another trial which studied exactly this is the ELITE trial, which looked at early versus late initiation of hormonal therapy. This is a 5-year randomized control trial. They divided them into two groups: women who were less than 6 years after menopause and women who were more than 10 years after menopause. And they followed them up for a period of 5 years. And what they found was in the women who received estrogen, who were less than 6 years post-menopause, there was the carotid intermediate thickness progression was lesser as compared to women who received it later, highlighting the relevance of the timing of hormone replacement in women as compared to, let's say, women who've had postmenopause for 10 years. So does this mean we give estrogen to all? Maybe not, but there's also evidence here from the Danish osteoporosis prevention study, a really long follow-up, a 16-year long follow-up, again in women who just attained menopause, which showed a 50% reduction in death, heart failure, and MI. Okay, so KEEPS and ELITE reassure us that the red alerts raised by WII probably not unfounded, but we have to pay attention to the women whom we choose to give hormonal therapy. So you would not be giving it in women who are more than 60 years, who've had menopause for more than 10 years, or who have clinically overt cardiovascular disease. And you would still also not give it to all women, which was one of the things which was being done in the times WHI was studied. The FDA-approved indications are these. But when you have a person who's walking in with these complaints, let the WHI not deter you from using it in a person who's likely to benefit when you've chosen the indications carefully. Moving on to aging male. So if that's the story of estrogen in women, what's happening with men? This is a representation of how there is a change in the hormonal levels through age. I'm going to leave DHEAS, which is showing a precipitous drop from the 30s onwards, to Dr. Jubbin to deal with, and I'm going to just focus on testosterone. That's in blue. You see that there is dropping with time, and you also notice that growth hormone, which is in green, is also dropping with time. So does this mean that both of these hormones could be played with, tweaked with, to optimize aging? So this is a very recent document published about 4 years ago, a position statement on the association of testosterone and cardiovascular risk, because there were many studies which said that probably there is increased cardiovascular risk. And this is a review of all the data that is available, and I'm doing this for paucity of time. And this is what the committee concluded, that the signal for cardiovascular risk with testosterone use is weak, and that we will still need to wait for definitive studies before we start excluding testosterone use in men just because they're above a particular age. And also, does that mean then we go about giving testosterone to everybody? We've learned our lessons from what happened to women. We're probably not going to do that. But we're probably going to evaluate men, listen to them, pay attention to their complaints. And if they have symptoms, you will have to then test their testosterone levels, at least on 2 occasions, drawn before 10 a.m. to document that they have a low total testosterone or free testosterone. And yes, this is something that we should keep in mind with age. Insulin resistance increases, visceral body fat increases, SHBG levels fall, total levels could falsely fall, might not be representative of what's going on. But if you document that on 2 different occasions, then you could have a conversation with that person, taking into account all of their risk factors, and to move forward. Dr. Jubbin will tell us all the concerns about cardiovascular risk, and we will listen to him. But we've had now set the ball rolling, equivalent to the safety studies which we had for estrogen in women, be it the KEEP study or the ELITE study. Similar studies named the testosterone trials, are randomized control trials which have been put in place to study individual aspects of testosterone and the effects that it has on aging. And a review was published about a few years ago to suggest that it does cause symptomatic improvement, but for us to say that it's cardiovascular safe, we might need to wait. But with the current data that we have, the risk is of weak evidence. That's something to be kept in mind. Again, I'm not encouraging wide testosterone use in all men who are symptomatic. We still need to follow protocol. Yes, we did speak about how growth hormone secretion varies throughout life. And there is a drop as early as 30. And this is a thing which is noticed both in men and women. And if you take a look at manifestations of growth hormone deficiency in adults, this could be any of us, right? Fatigue, lack of energy, very non-specific, depressed mood, depressed muscle strength, decreased lean body mass. So they are very vague, non-specific. It could very well be a person who has just metabolic syndrome and lots of work and COVID to deal with, right? So how loose should your criteria be for testing, and should you test normal individuals for growth hormone deficiency who don't have a history of hypothalamic pituitary insult? Has been a question which has been asked many, many times. And this is the long list of causes which can lead to pituitary defect or growth hormone defect. And somewhere down in the corner, you see that there's idiopathic, right? And this is data from one of the largest surveillance follow-up data, which has looked at adults who've been on growth hormone. Of course, the most common cause has to be pituitary adenoma, right? But notice that the second most important reason why adults are getting growth hormone is idiopathic. Now, it could mean 2 things. It could mean that we are overprescribing growth hormone, or it could be that we have documented growth hormone deficiency and not identified a pituitary or a hypothalamic defect, right? But as Professor Chowdhury has identified, there is definite increase in lean mass, there is decrease in fat mass, there is increase in BMD, bone mass. There's also evidence to suggest there's increased improvement in quality of life. But and this is one interesting paper published recently. This is a meta-analysis which took individuals who were receiving treatment for osteoporosis and did not have growth hormone deficiency. This is about 8 studies. And on top of the treatment that they were receiving, one arm received growth hormone and the other arm did not receive growth hormone. And overall, the patients who received growth hormone seemed to have a significant decrease in fracture risk over and above offered by standard therapy. So probably there's something here that we need to look in in the future more carefully and not dismiss it as something that, let's say, pharmaceutical companies are trying to push down our throat. So I'm going to keep my mind open when it comes to growth hormone. An interesting hormone is melatonin, and this is probably the last aspect I'm touching on. Melatonin is secreted by the pineal gland in response to light and darkness. And there is documented evidence that the secretion of melatonin is highest when you are in your 20s and falls as you age, okay? And melatonin is a powerful antioxidant, Melatonin also is an important immunomodulator. And that is one of the ways it connects the circadian rhythm to your well-being overall. But this is a pictorial representation of two monozygotic twins, and patient NN had received melatonin for about 36 months at a stretch, and patient ZZ hadn't, and this is to suggest that there is decreased atrophy in the cerebral area after 36 months of melatonin use. And this is mice data to suggest that when treated with melatonin, there seemed to be an extension of life by about 3 months. Again, this is data from animal world. And another important bit of data I found is this about melatonin levels after fasting. Notice that after fasting that the melatonin secreted by the gut, which is the stomach, increased. The one universal thing which is known to reverse aging or prevent aging is caloric restriction, right? And I was wondering if melatonin is the connection which links fasting and mitigation of aging. And the world has woken up to this bit of information, as evident by the number of papers which have been published on melatonin and aging in the last few years. But of course, there hasn't been a randomized control trial which has been done. But I know that melatonin is one of the most, let us say, over-the-counter abuse medication, which many people are using to maybe prevent aging in their own realms. So maybe when we're talking about mitigating morbidity related to aging, we are not probably looking for the mirage of a fountain of youth and being thrown off by the fact that it's not evident, but probably we're just looking at aligning numerous cogwheels and tweaking them a little bit to overall effect a change which alters for the better the life of the individual, be it addressing bone health and the use of teriparatide or other agents to improve the risk of their risk of fractures, be it reduction of falls by using vitamin D, being targeting diabetes control with insulin or other agents, looking at screening for growth hormone, estrogen, and menopause, and addressing those aspects of care. And it's now very well established that you could be still experiencing hot flashes and having mood swings related to menopause for up to a decade after the menopause itself happened. And keeping our eyes open to pick up hypogonadism, documented of course. Also think of how growth hormone deficiency might not be so uncommon outside the realm of hypothalamic and pituitary disease, and probably somewhere in the future we will be talking about melatonin as well. So do you think we can mitigate age-related morbidity with hormones? Yes, even within the realm of our own clinics with the help of evidence-based medicine. And with that, I hand over to Professor Chowdhury.
Thank you, Chitra. That was enlightening, and it covered a broad arena, of course, starting with parathormone analog and going down more sort of discussed issues like estrogen, testosterone, growth hormone, and all that. And of course, ending with melatonin. So we will now move over to Dr. Jubbin Jacob, who will oppose the motion. The motion says that hormone treatment or hormone replacement can mitigate age-related morbidity, meaning to a certain extent, of course. And Dr. Jubbin Jacob is an excellent speaker once again. And in fact, whenever I have invited him somewhere to give a talk, I've already felt maybe it would be good if I could have a copy of his slides. But of course, his presentation, it's not just the slides, the presentation also matters. He is a professor of endocrinology and diabetes at the Department of Medicine at Christian Medical College in Ludhiana. He is also associate editor of our very own Indian Journal of Endocrinology and Metabolism. And he is, of course, academically very well-versed, and has been involved in multiple national and international clinical trials, including such well-known ones like the Pioneer 6 or Examine and so on and so forth. So it's over to you, Jubbin, to try and prove what Chitra has said is all wrong. It's only a biased view of an endocrinologist. And though you are an endocrinologist, possibly you can try and say whether she's all wrong.
Thank you, Dr. Subhankar, and thank you, Intas, for calling me Chitra. I think the way I think Chitra has looked at the forest of aging is look at trees. She has looked at osteoporosis, she has looked at diabetes, she has looked at frailty. But I think I'm going to look at the whole picture here. And for that, I'll start by saying that we do not have a circle of life. It is probably Chitra's child believes in this, Walt Disney believes in this. But what we do have is the truth that we are going to be born and we are going to die. And we are going to be living for a period of time. And that life is going to relentlessly march you towards the grave. And that is the period of time we have in between. When you die, we call it your lifespan. And when you're alive, you call it the life expectancy. And I think Chitra very clearly showed you that life expectancy with all the modern medicine that we have has now increased in at least 26 countries, high-income countries with good socialized medicine. It is as good as 80 years. And Chitra will tell you that it's probably about 82, 83 in women and about 77, 78 in men in the best of economies, in the best of healthcare that you get. So now let's look at this life expectancy. And I'm going to introduce some new terms here. Let's say the best of life expectancy is about 80 years. We have another term which we called, and this best of life expectancy in a country like Scotland, you get utilizing almost 40% of their overall budget is used for health. And so that's how they have got that 80 years of life expectancy. And now when we look at a different term called healthy life expectancy, that is the amount of the number of years you're going to be healthy and active, then you realize that it is not as good as what we thought in the last 50 years. We have actually not increased. That means most of those patients years are going to live healthy for about 70 years and are going to have compromised life for another 10 years. When I say compromised life, it may be functional, it may be physical compromise, it may be mental compromise. It is living in nursing homes, living in care facilities, living with a carer full-time with you. So this is the kind of life expectancy that you expect with all the kind of advancements that we have currently. So what should we do? I think the whole question here is, can we do better than this? Can we increase the amount of healthy life that we have and reduce the amount while keeping the life expectancy the same? Let's say reduce it to 2 years. And there is a hypothesis which is called compression of morbidity hypothesis. So this was about postulated about 10 years back. And what they clearly showed is that if you decrease age-related morbidity, which is exactly the debate topic for today, that means if you postpone age-related morbidity, you postpone the onset of diabetes, you postpone the onset of renal failure, you postpone the onset of cancer, you will may not end up with an increase in life expectancy, but you will end up with longer, healthy life expectancy and a shorter period of compromised life. And today's question is whether hormonal manipulation is going to decrease that age-related morbidity. And I'll quickly go through it. And I think Chitra is in very good hands. I think if you remember, this is Charles Edward Brown Sequard. He's a gentleman who's now been considered the founder of endocrinology. He was the first man to actually believe that there were secretions and call them hormones. And he removed an adrenal gland. And most of us know him as a very accomplished neurologist who first described the spinal pathways. Now, what happened with him was actually very sad. For about 30, 40 years, he was at the peak of his achievements. And then around, I think, 1965, he wrote this paper in the Lancet, and he also presented it at the Society for Biology in Paris, which is the effects produced in man by subcutaneous injection. And most of this he did by injecting himself with these animal testes extracts, and he injected himself and he started believing that it produced in him a rejuvenation. He felt much better. Exactly all the things that that Chitra was talking about. He felt more energetic. His muscle strength improved. He had sexual rejuvenation. But unfortunately, that was also one of the reasons why he lost most of his standing. Most of the people started believing, and the kind of articles that came about. This is a note in a Austrian journal where they said this lecture must be seen as proof or the necessity for retiring professors who have attained their 3 and 10 years. So I think so. Chitra is in good hands. Founder of endocrinology. I think we have re-evaluated his contribution, and that is why about 20, 30 years back, people have now started considering him as the father of endocrinology. My outline is basically, I'll quickly spend 5 minutes talking about the endocrinology of aging. I'll talk about the impact of hormonal manipulation on this aging. And when I talk about impact, it's probably the lack of impact that I'm going to highlight. Finally, I'm not going to leave you with bad things, or I'm going to leave you with a positive, this thing that we can compress this age-related morbidity. We can get a more healthy lifespan and reduce the compromised lifespan that we have. And how to do about it, I think I'll spend the last 5 minutes with that. So let's start with endocrinology of aging. And I'm like our president, Dr. Sanjay Kalra, I'm going to start using some new words. Well, the first word I'm going to use is thyroid aging. And I think most of you know that as you grow older, there are more chances of having thyroid dysfunction. Subclinical hypothyroidism over the age of 65 is very common. And if you look at longitudinal studies of aging people, you would see most of them would have about a 13-14% increase in TSH values as you grow older. There is usually no change in free T4 values. And if you look at the T3 concentration or the free T3 concentration, there is a decline. And I think now the science is very well explained that it is primarily driven by a decrease in peripheral conversion of T4 to T3. And that is why we have lower T3, normal T4, and an increase in TSH. Now, this is not what Chitra is interested in, because it is not, giving them hormones are not going to make any difference here. So let's forget thyroid aging, look at glucoaging. And I'm sure Chitra showed you that a lot of patients, as they grow older, are going to develop some degree of glucose intolerance. It's as high as 40% at the age of 65. It goes up to as high as 50% while you're at the age of about 80 years of age. And we know the reasons for it. It's both a decrease in insulin secretion from the beta cells and also an increase in insulin resistance. Glucoaging is something that you're going to encounter. But like Dr. Chitra said, insulin is not going to be the panacea for glucoaging. It is not going to help you live a longer, more health and have a life expectancy that is more healthy. Now, bone aging is, I think, Chitra has talked a lot about osteoporosis. We know bone aging, you attain your peak bone mass by the age of about 30. You have fairly static bone mass for about 20 years, and things start declining after the age of 50. Most of us believe there's a lot of contribution of the gonadal hormones onto this loss of bone mass. But there is also what I would consider bone aging, that Chitra already discussed, that there is decreased conversion of active vitamin, conversion from cholesterol to vitamin D in the skin. You are, as you grow older, you are less good at converting or making your own vitamin D in your skin. Your parathyroid gland starts producing more parathyroid, whether it is part of aging itself or is it a response. There are aging happening within the bone itself. There is increased conversion of cortisone to cortisol in the bone. There is a change in FGF23. How that impacts, we are still not clear. So there is a definite bone aging which is independent of what is happening to our gonads and the decline in gonadal functions. But these are not the interesting things. Interesting things are the pauses. And I think Chitra spent some time talking about menopause, but I think as endocrinologists, I think we have done a great disservice by using the word pause. I think we have used the word pause quite a number of times, and now we have at least 4 well-described pauses. And when you hear that word pause, let's say you're listening to music and somebody pauses the music and you're really enjoying it, and then you're always looking for some knight in shining armor to come and unpause and get you back to your music, get you back to your jive that you were really enjoying. So that is why I dislike this word pauses, but I look at some of the pauses that we have in endocrinology as we grow older. The most important of that is menopause, happens around the age of 50, considered to be primarily a gonadal exhaustion of the follicles leading on to a gonadal failure. And I think Chitra has already described, and then it leads to an increase in cardiovascular disease, increase in osteoporosis, also increase in dementia. But I think we are now realizing it is not just a gonadal failure. As women grow older, there is also some degree of decline in pituitary gonadotropin secretion as well as you grow older. So menopause is one of the first pauses, well-described pauses, but then there are some of the more poorer described pauses. Menopause happened when you were 40. Andropause happens when you are, menopause happens when you were 50. Andropause happens about 10 years earlier. When you're 40, you start declining free testosterone levels. If you look at the first panel, you can see the testosterone level doesn't change much. But most men at the age of 40 will start having a decline in free testosterone levels. And that is primarily because of an increase in SHBG levels. And you can see then in about 5-10 years, the luteinizing hormone also starts going up as you age. And we call this andropause. And I think I'll discuss how the treatment for this is not going to make any impact on your healthy life expectancy. Now we have a very interesting third pause, which we call adrenopause. Now, if you look at it, things are now happening 10 years earlier. Adrenopause, menopause happened at 50, andropause happened at 40, adrenopause is now happening at the age of 30. And this happens in both men and women. It is primarily the zona fasciculata, which starts producing lesser amount of sulfated DHEAs. And that you can see the decline continues. Starting at the age of 30, it continues for the rest of your life. And you have now a pause, which is going for almost most of your life. With menopause, you had 30 years of menopause. With andropause, you had half your life. You are with andropause. With adrenopause, you're now spending 50 years under the pause of your adrenal production of DHEAs. Finally, I think the most interesting pause or the most controversial pause is what I call the somatopause, or the decline in growth hormone and IGF-3. And that happens right after puberty. So menopause was at 40, andropause started at, menopause at 50, andropause at 40, adrenopause at 30, and somatopause is starting right in the 20s. So that means if I'm going to manipulate hormones to try and get you a better life, I'll have to start right at the age of 20 with growth hormone. And the decline in growth hormone, it's not just a decline in growth hormone, it's also a decline in IGF. It is not an increase in resistance to growth hormone effect. So once we have understood these 4 pauses, I'll discuss primarily these 4 pauses and the impact of hormonal manipulation. Now, when we talk about music being played, and this is a band, this is a 5-piece band. You can see there are 5 people in the band. At the age of 20, your drummer has stopped drumming. So that means now your music is a 4-piece band is playing the music. At the age of 30, men and women have adrenopause. So your keyboards have stopped functioning. Now you're limited with your female vocalist, your bass guitarist, and your lead singer. And at the age of 40, the bass guitarist has also stopped functioning. And now, then at the age of 50, you had menopause. So anyone over the age of 50 is, if we believe in these pauses, is essentially playing music with just one instrument and a single vocal. That is what is happening. So let's see whether we can, get these pauses to unpause themselves and start playing the music again. So let's start the other way around. I started with menopause, went to somatopause. I'll start with somatopause because that's the first thing that's happening at the age of 20. At the age of 20, we've had a decline in growth hormone and IGF. and our drummer has stopped playing the drums. What shall we do? Shall we start growth hormone? And I think Dr. Chowdhury also talked about the amount of information that is available in the net about growth hormone being the fountain of youth, being the elixir of youth. And as it also showed us the graph of adult growth hormone use, and there is a lot of idiopathic use of growth hormone. And I think that primarily is driven by people who know that their patients don't have growth hormone deficiencies, but they want to give them growth hormone because they're insisting on growth hormone. So that is why there is a huge amount of what is called idiopathic growth hormone treatment. And if you look at the basis on which growth hormone treatment has been advocated as a way to get young, I think the paper is in 1990. It's been 30 years. And if you look at the paper, this is the use of or the effect of growth hormone. It is about 30 odd patients. 30 odd patients on whom growth hormone they used for about 2 years. And they found that it increases lean body mass, it decreases adipose. It was not even a randomized control trial. It was a plain observational study, and it showed that it improved bone mineral density. And this is the paper based on which so much of growth hormone, the unscientific use of growth hormone is actually a $2 billion industry now. And there are these anti-aging clinics where orthopedicians, where dermatologists mass prescribe growth hormone without any testing whatsoever. And I think, I'm sure Dr. Chitra and everyone will agree with me that growth hormone is not, 60 years of growth hormone is not going to lead you to a better life. Now let's look at DHEA's replacement. This starts at the age of 30. So if you are going to replace DHEAs, the adrenopause, you're going to mitigate that. You're going to have 50 years of DHEA replacement. Again, we don't have any studies which looked at 50 years of DHEA replacement. I think the one well-done randomized control trial was the use of DHEAs in elderly men and women. And the conclusion was very clear that neither DHEAs nor low-dose testosterone replacement in elderly people had any physiological relevant beneficial effects on body composition, physical performance, insulin sensitivity, or quality of life. So I think we can forget about replacement for DHEAs or unpausing adrenopause with DHEAs. Testosterone replacement therapy. I think Dr. Chitra was very convinced about testosterone replacement therapy. But if we really believe that andropause needs treatment, that means about 50% of your life you should be on exogenous testosterone. That means you start at the age of 40 and you continue for the rest of your life. This is not going to be a panacea because we know that we have used testosterone in late onset hypogonadism. We have used it in patients who came with specific sexual symptoms. They did not come to live long. They did not come to you because they want to have a healthier old age. They came to you because they had sexual dysfunction. Yes, definitely. It improves libido, it improves erection, it improves sexual activity, it increases some amount of BMD, but it's not going to help you live long enough. It is not going to improve your mental functions. It's not going to change your cognition. In fact, it might harm. Chitra was very careful in telling us it may not harm. It may not harm, but it is not going to benefit in terms of your cardiovascular disease, in terms of your stroke. If anything, all the data is suggesting it might harm. So that is the end of testosterone replacement. So we've now come to the last pause, that is hormone replacement therapy for menopausal women. I think Dr. Chitra made the case herself. We were worried about cardiovascular disease, osteoporosis, dementia that was happening in women after menopause. And I think the Women's Health Initiative took the first step in deciding, okay, if this is all happening after menopause, we need to give them hormone replacement therapy for the period of time that they have after menopause. That's approximately 30 years in a high-income country, and they recruited patients looking at that. The idea was not that they recruit patients at the time of menopause. They recruited patients because the idea was every woman after the age of 50, once they've attained menopause, should be on hormone replacement therapy. And with that, they did get, they looked for hard outcomes. The numbers are huge, 16,000 patients on a combination pill, 11,000 on just estrogen who had hysterectomy or a surgical menopause. And it was very clear the hard outcome said you are going to have more risk of cardiovascular disease. You're going to have some benefits in osteoporosis, but you're not going to do anything to dementia. Now, I think Dr. Chitra told us about some other trials, the KEEP trial, the ELITE trial, and she said that it is not a good thing to give hormone replacement therapy for the whole 30 years after menopause. Give it for 10 years, give it for the first part. Again, but what she has told us is we've had hard outcomes saying that things are not good, and then she has told us that it might not do anything bad to the coronary artery calcium score. It might not do any harm to the carotid intimal thickness. In fact, she showed a small paper where it actually improved carotid intimal thickness. So these are all you remember. These are not outcomes that are hard outcomes that the WHO trial has shown us. These are all surrogate markers, and these are not going to convince me to prescribe hormone replacement therapy for long life or to reduce age-related morbidity. I would still prescribe hormone replacement therapy for patients for going or to cope with the menopausal transition for a period of time. So now, once you're convinced that the endocrinology of aging is going to happen, the music is going to, there is no pause anywhere. Most of it is a slow decline in hormones that is part and parcel of aging. That happens not just to endocrine hormones, it happens to your nephrons. Your EGFR declines every year, your declines every year, you lose hair every year of your life, you lose hair. All of that is part of normal aging. But I want to leave you with, can we compress morbidity? That means we had the compression of morbidity hypothesis. What I convinced you is hormonal manipulation is not going to decrease age-related morbidity, but can we do something other than hormonal manipulation? I want to leave you with good news. Yes, you can. And I think the paper was not a new paper. This is almost 20 years back. James Fries came up with this paper. It is a very elegant paper. It's actually very, very simple. What he did, he worked in the University of Pennsylvania. He had he recruited about 1,700 alumni from UPenn. He saw them in 1960 for the first time. That means he saw these 1,700 alumni from the University of Pennsylvania in 1962. And these were all, because they are universities alumni, they are all on the same age, almost the same age. The average age was about 43. And you can see, let's look at 3 risk factors. He looked at smoking, he looked at BMI, he looked at the amount of exercise they did at the age of 43, and he divided them into 3 groups. Low risk group, obviously that is a group that will not be smoking, that has a good BMI, that is exercising regularly. He had a moderate risk group, that is obviously smokers and those who exercise. And then he forgot about them for about 24 odd years. He brought this group back again in 1986. At this time, they're about 24 years older. The average age is about 67 years. And now what he did, after the age of 67, he looked at them every year. And he looked at the same group, 1,700 odd alumni from UPenn. He looked at them every year. He looked at how they are doing in life every year for the next 10, 15 years. And this is what he showed you. Those who had low risk in 1962. Now, this is the x-axis is something called disability index. Now, disability index is the level of independence that you have, both in terms of physical and intellectual independence that you have. And you can see there is a line in the center that is 0.1 is when till 0.1, you are considered to be living a healthy, independent life. Above that, you're living a compromised life. And you can see very nicely, those who were at low risk were doing very well all these years as he saw them every year. You can see those who were at low risk at the age of 43 in 1962 were doing very well in 1987, going up to 1994. This is a little complicated graph because you have to remember that many of these patients are at different age groups. At 1993, some of them may be 75 years old, some of them may be 68 years old, some of them may be 79 years old. So we put this into a much more easier to understand. We've now put all this data into ages, and we have looked at what is happening to their disability index at various ages. You can see the low risk group. At the age of 78, most of them are still active. That means they are independent, they do not have a compromised life. And that brings us to exactly what we wanted. We wanted 78 years of healthy life expectancy, and that you can achieve by being on the low risk group. We can see what is happening to the high risk group. High risk group, you can see by the age of 68, most of them are now disabled, or the sense they're not independent anymore. And now the next 10 years they spend as compromised life, as persons in nursing homes, or people with carers, or people in assisted living institutions. And the one in the center is what we see in most high economies, or most economies, or high income economies with good socialized healthcare system, that despite all the advancements that we have, most of our patients will have 70 years of good life expectancy or healthy life expectancy. This healthy is not an absence of disease, it is being functionally healthy, and another 8 years where they will have compromised lives. So I think this graph tells you that if anything that is going to change or decrease your age-related morbidity, it's definitely not hormones. It is an early adoption of a healthy lifestyle. So now I want to again go back to the pauses that we had and the music band that we had. And we said that at the age of 20, you're going to get somatopause. And I think when you develop at the age of 20, when you develop somatopause, rather than giving growth hormones, you develop a good, healthy lifestyle. You start avoiding fizzy drinks, you stop smoking, start alcohol, or use alcohol in moderation. At the age of 30, when you develop adrenopause, I think the thing is to start exercising. At the age of 40, I think calorie restriction, intermittent fasting, these are things you can adopt. Healthy lifestyle you can adopt at the age of 40 when you actually achieve what is called andropause. And at the age of 50, when you attain menopause, I think it is the time to start mindful living, start meditation, and get stress levels down. A combination of all this is going to get you what we wanted from hormones, will get you longer lifespan. More important than a longer lifespan, will compress your morbidity to the last part or the last quarter of your lifespan. Most of the chronic diseases will go into your last quarter, the diabetes, the hypertension, the cardiovascular disease, and you will have a very small period of time where you will have what we call compromised living, and you will have 75, 78 years of what we call as healthy life expectancy. So I think I'll stop here. We don't need to unpause some of the pauses that are happening with our hormones. We need to get ahead of it. We need to adopt healthy lifestyles, and these healthy lifestyles need to be adopted early for us to get all these benefits towards the end. So I think I'll stop here, and I'll stop sharing my slides as well.
Thank you very much, Professor Jubbin Jacob. That was marvelous, wonderful, which was informative and also had a little bit of philosophical approach to managing aging. So we will allow Chitra maybe a couple of minutes for rebuttal.
Thank you, Professor Chowdhury. Thank you, Professor Jubbin Jacob, for that talk. This is probably one of the few debates where we seem to be in agreement, found our own patches where we are happy, which aligns with probably our thought processes, and yet managed to finish our talk. But I strongly think that this is a very utopian view to how aging is supposed to be. And I don't think I can tell a 50-year-old woman who walks in with her life thrown apart in the midst of hot flashes to think about mindful living and meditation. I will not survive that even as a woman endocrinologist, not in the age of feminism. Leaving feminist aspirations aside, I really, really think that, yes, while we do not want to cause harm by unnecessarily meddling with the hormonal milieu, it is absolutely necessary that we keep our eyes open to at least identify the hormonal imbalances, which we can probably address very well within the realm of scientific evidence. We don't need to be doing concoctions of injections, and there are numerous clinics which are thriving, and you do have throngs of people crowding to them. Maybe we don't have to offer that and be absolute proponents of giving cocktails of all the hormones, but if you're just doing what we're doing, keeping our eyes open, conducting relevant, clean scientific trials to advance knowledge, to make sure that we are improving quality of life without increasing harm to our patients, I think towards that end we must absolutely work. And I really don't think that mindful meditation is the thing that I would recommend to people who are coming with absolute complaints. I would listen to them, pay attention to an examination, and evaluate and treat. Over to Professor Chowdhury.
Thank you very much. We have quite a few questions on our chat box. Maybe we'll address a few. And one of the questions, of course, was what the debate was all about. Dr. Diptendu sent in a question: can hormone replacement mitigate common morbidity related to aging? Of course, maybe you wait till the end and try and get your own answer out of the different points that have been made. So first to Dr. Jacob. So this is Dr. Abhik Dash. He would want to know the dose of thyroxine for subclinical hypothyroidism, which occurs more commonly in elderly. So what dose would you use, or meditation? Please unmute yourself.
Yes. So very clearly, I am not advocating any hormone replacement for reducing morbidity on a long-term basis. But hormone replacement is required if you have a hormone deficiency. So I'm not saying that a man at the age of 45 who comes to me with sexual dysfunction, and a late onset hypogonadism, I'm not going to treat him with testosterone. I'm going to treat him with testosterone, but with the very clear indication that I am treating him for his sexual dysfunction, not for his long-term to change his life or give him a long life. The same with a 50-year-old woman who walks into my clinic with menopause. I'm not advocating I'm going to tell them mindful meditation, but I'm definitely going to advocate them that I'm going to give you hormone replacement therapy. This is for managing your menopausal transition, not to give you a long life, not to give your youth back to you. So that is, I think, the message that I was going to convey. But again, here the question is, what should I do with an older person with subclinical hypothyroidism? I think the guidelines are very clear. Everyone does not require to be treated. There are very clear-cut indications whom to treat, whom not to treat. I think I'll follow those indications, and I'll use the dose depending on what the degree of subclinical hypothyroidism. And in older patients, I would start the doses much more slowly, a small dose, maybe 12.5, then go up to 25. And but I think the indications for treating subclinical hypothyroidism in the elderly are very clear.
Yes, and I'm absolutely right. Again, possibly in the elderly, we will not be treating unless the TSH is really above 10, and there's suggestion that unless it's really above 20. And even if there is someone who is on replacement treatment, our target TSH is much more relaxed in the elderly. So now for Chitra, you have mentioned about PTH analog for preserving bone health, teriparatide and abaloparatide. So the question was from Dr. Kishore Deshpande, and he wants to know about parathormone and aging. I mean, does it decline with aging? What happens? And also the broader question of relationship to osteoporosis. That, of course, is maybe easier to answer, but relationship of parathormone levels with aging.
Honestly, I've not thought about the relationship of parathormone to aging at all, and I have not looked it up at all.
Right. So I think in one of my slides, it was clear that parathyroid hormone levels actually go up with older age. So,
okay, thank you for that, sir. But what the second question was about parathormone and the effect on the bone.
Yeah.
Yes. So parathormone is anabolic to the bone. Parathormone acts on the osteoblasts and increases local production of IGF-1, which then gets osteoblasts to proliferate and form new bone. And that's how it increases bone strength, bone architecture, and also brings down the risk of fractures. So although PTH levels might not be low, the protective effect that the gonadal steroids offer on the bone is mediated through these same mechanisms, because of which the IGF-1 levels in the local bone milieu comes down after menopause or andropause, and PTH kind of steps in and increases IGF-1 levels in the local area to cause the growth of osteoblasts. I hope I answered your question.
Yes, and of course, we need to remember maybe whether the PTH is very high, whether it's high for the entire duration of the day or only parts of the day, that also possibly decides, because we clearly do have increased fractures with hyperparathyroidism, primary hyperparathyroidism. So yeah, that's a tricky area, though. Yeah. Right. So, and yeah, please go ahead. Please go ahead.
I just thought I should clarify that. So with PTH, the continuous exposure versus intermittent exposure seems to be the key difference. So if the bone is exposed to PTH high levels throughout, then it's likely to cause greater bone resorption, as occurs in primary hyperparathyroidism. But when you're administering PTH as an injection every day, that would be intermittent administration of PTH, which then selectively seems to trigger osteoblast growth over bone resorption, and that is for a finite window of 18 to 24 months, what is referred to as the anabolic window, and that is what we're trying to cash in when we administer PTH. I did show a slide, although I didn't have the time to pause and explain that nuance. Thank you.
Right. Yeah, thanks. So, and now Dr. Sanjeev Varma, he wants to know the minimum tests to establish growth hormone deficiency in the adult or the aging population. Maybe it's to Dr. Jubbin Jacob, because you are okay to treat if they have got definite deficiency.
Yes, so I think the FDA has very clearly said that, many drugs, most drugs, it just gives you an indication, but it does not say you have to fulfill the indication. It tells you, but with human growth hormone, FDA has very clearly said if you're going to use human growth hormone in an adult, you need to establish growth hormone deficiency with a stimulation test. And what stimulus we use is up to you. The gold standard is stimulating growth hormone secretion via hypoglycemia by injecting a controlled dose of insulin. So it's called insulin hypoglycemia test, and that is the gold standard to establish adult growth hormone deficiency. There are other stimulation tests, but they are not so commonly used in adults. I think the gold standard is still insulin hypoglycemia test. But if you have a pituitary disease and you already have 2 or 3 hormones with that deficient, you can straight away treat those patients with growth hormone without establishing. But for all those idiopathic causes, I think without establishing growth hormone deficiency, giving growth hormone is, opening ourselves to quackery.
Yeah, and it's the difficulties of conducting this insulin hypoglycemia test as well, and especially in the elderly who may also have underlying coronary artery disease. It's also not an easy test to perform, right? And then maybe we need to wind up soon, but one to Dr. Chitra. This is from Dr. Das. Do HRT have any role after the age of 60 in decreasing mortality or morbidity? We have had allusion to this issue, but maybe Chitra, you could summarize.
of all the trials which have looked at hormone replacement therapy, I think the longest was with the Danish osteoporosis study, in which the replacement was given for about 11 years and followed up for about 16 years overall. So for now, we have data to suggest that it is safe to be used from the date of onset of around the time of menopause for about 11 years or so. And going back to the point which Dr. Jacob did say that, does that mean we do not give hormone replacement therapy to a 60-year-old? I think it's more about how early or closer to the time of menopause you start. That's called the timing hypothesis. So when you've had menopause for about 10 years or so, the process of atherosclerosis is kind of set in. And when you give estrogen plus or minus progesterone, it is likely to accelerate. That's the theory. But when you initiate estrogen closer to the time of onset of menopause, you're likely to retard the progression. So that is the essence of the timing hypothesis of hormone replacement around menopause.
Right. And I would once more maybe sort of trying to come to the end of this day's discussion. There is a significant amount of disconnect between theoretical supposition and clinical evidence. For example, there is a whole lot of possibility that estrogens could improve cognitive function. And there's some evidence out there as well. But possibly in clinical practice, you do not see that translating into real benefit. That is one. The other is also based on clinical trial evidence. The practice also changes over time. And I do remember the 90s when it was almost, if you did not talk about hormone replacement treatment to a menopausal woman, you are not doing enough service to that lady. And there was a lot of expectation and demand also that you should be taking. And now it's gone the other way around, that if you are offering hormone replacement treatment, you are not doing the right thing. So let's see whether the cycle comes back once more. We do not know. I mean, fashions coming and come and go. Partly it's the same. For example, the use of aspirin in diabetes. Maybe 15 years back, you had to give aspirin to every person with diabetes. Now you give to only select number of patients. And sometimes you sound a bit foolish when the patient has been on aspirin. Next time when the patient comes, you say, who has given you aspirin? Why are you on aspirin? And then the patient tells you, you only had prescribed me a couple of years back. But once again, last year, I think Nature, and because it's a paper published in Nature, that's why I think it aroused a lot of interest, which looked at a relatively small number of individuals, maybe 15 or so, and treated them with 3 agents: growth hormone, metformin, and for Jubbin, DHEA, and followed them up for, I think, not a very long period. But the interesting part was they looked at epigenetic clocks. I don't understand a whole lot about them, but what they found was that this sort of combination, it did wonders, and it sort of changed the epigenetic clocks and sort of turned the clock back. So suggesting that this could lead to, once again, going back, could be an elixir of youth or whatever. But again, as we all know that at this point of time, we do not have a panacea. We do not have a sort of cocktail, shotgun, where we mix together 4 or 5 hormones and give to every individual and prevent the aging-related symptoms. But as Chitra very correctly pointed out, I'm sure Jubbin also accepts and agrees that we need to be aware of the symptoms of deficiency, which quite often are quite subtle, and our correct intervention can, of course, help them improve their quality of life. So we had an excellent program. I congratulate both of you, Chitra and Dr. Jubbin Jacob, for an excellent presentations, and also our audience who have made it lively by asking questions. And I am told there were about, at least at some point of time, there were about 1,000 doctors who were live listening to all your wisdom, pearls of wisdom. And so I thank all of you. Have a good time, have a good night, and stay safe, stay well. It's over, back to the organizers.
Thank you so much, sir. On behalf of Intas Pharmaceuticals, myself, Mudit Prashant, General Manager Marketing, extends vote of thanks to our eminent course director, Dr. Professor Subhankar Chowdhury. Sir, without your able guidance, we would have not have this journey of 5 successful webinars till today. So thank you very much. And I would also like to thank the esteemed faculty, Dr. Chitra and Dr. Jubbin Jacob, for a very lively and very interesting and very, very informative debate on age-related morbidity and hormones. Over 1,000 plus delegates have joined in live today, sir. And I would like to thank every delegate for their valuable time and presence. I just like to is happy to inform about the next session. The next edition of this program will be held on 21st November. And we look forward for all the delegates to please join us again. I would also like to thank the backend team who has helped us for this streaming of this event across India. And nonetheless, all this academic initiative would have been possible because of the support for our TGLIP, TGLIPM, and Lipicure. So wish you a very, very happy festive season ahead because we're going to meet, all of us are going to meet after Diwali and Dashara. So wish you a very happy festive season ahead. Thank you so much, sir. Thank you, everyone.
Thank you.
And thank you, Dr.
Good
Mitesh.
night.
Thank you.